Welcome everyone. Today's topic is on extraoral radiography part 1. Extraoral radiography means that the source as well as film are placed outside the mouth and an exposure is made in order to obtain the images on a recording medium. Indications are whenever intraoral film radiography is not possible, when the extent of the lesion is large, when the facial bones and the jaws have to be studied to see the evidence of any disease or pathological condition, to evaluate skeletal growth and development, to evaluate the status of impacted teeth, trauma, and the temporomandibular joint areas. The drawbacks, first and foremost, is the magnification because of the greater objective film distance. Details obtained are not well defined as seen in intraoral periapical radiography or intraoral radiography. Contrast is reduced as the secondary radiation produced by the soft tissues is more. Coming to the equipment, we require an X-ray unit, which either consists of an intraoral X-ray unit or an extraoral X-ray machine, panoramic X-ray unit, and a cephalometric X-ray unit. Films, you can use extraoral non-screen films or extraoral oral screen films and OPG films. Coming to the film sizes, the panoramic imaging uses 5 into 12 and 6 by 12 inches film. Transcranial lateral oblique jaw radiographs require 5 by 7 inches and skull radiography cephalometry requires 8 by 10 inches. Coming to some extraoral landmarks which are very useful while making extraoral radiography. First and foremost is the mid-sagittal plane, as you can see in the image over here, drawn in the midline of the face. The second is infraorbital line, as the name suggests, infraorbital. So the line runs below the intraorbital margins of the orbits. The third is the ortho-orbitomeatal line or the canthomeatal line. That line comes from the lateral canthus of the eye to the center of the external auditory meatus. And the last is the Frankfurt horizontal line, which runs from the lower part of the orbit to the superiormost part of the external auditory meatus. Extraoral radiographic projections can be categorized into panoramic and other projections. Under that, we have posteroanterior projections, also known as occipitofrontal projection of nasal sinuses. Under that, you have posterior anterior view or the Granger projection and the modified view. Radiography of the maxillary sinus, we have the standard occipitomental projection, which is 0-degree OM view, modified method 30-degree OM view, PA Waters view, and the Bregman-Menton view. Next is radiography of the mandible. Under that, we have PA mandible or posterior anterior mandible, rotated PA mandible, lateral oblique projections. Radiography of the base of the skull, we have submental vertex, and radiography of the zygomatic arches, we have a jug handle view, which is a modification of the submental vertex. Then we have radiography of the temporomandibular joint. Under that, you have transcranial, transpharyngeal, transorbital, and reverse Townes view. Radiography of the skull, which includes lateral cephalogram, true lateral cephalogram, PA cephalogram, PA skull, and Townes projection. Now coming to the radiography of the paranasal sinuses. Under that, we have posterior anterior projection, that is Granger projection, and Caldwell projection. Posterior anterior projection, also known as occipitofrontal projection of nasal sinus. This projection shows the skull vault, primarily the frontal bones and the jaws. So the indications are fractures of the skull vault, investigation of the frontal sinuses, conditions affecting the cranium, particularly Paget's disease, multiple myeloma, or hyperparathyroidism. This view is also important to evaluate the facial growth and development, trauma, and developmental abnormalities. This is how a PA view is seen. We can clearly see the frontal sinuses, which are the radiolucent area seen in the frontal bone. We have the orbits, we have the sphenoidal plane, the ethmoidal sinuses, the petrous ridge, and the inferior orbital margin. These are the maxillary sinuses. Next, you have the posterior anterior Granger projection. It is excellent for viewing the frontal sinuses, anterior ethmoidal sinuses, sphenoidal sinuses. Coming to the film placement, the cassette is placed 90-degree to the floor in a cassette holding device. As you can see in the image over here, the long axis of the cassette is positioned vertically. So this requires a standard panoramic unit for making all these radiographs. Next is coming to the position of the patient. As you can see in the picture over here, the forehead and nose has to touch the cassette, which is typically termed as forehead nose position. The radiographic baseline, that is the cantomeatal line, is horizontal and at right angles to the film. This positioning levels off the base of the skull and allows the vault of the skull to be seen without superimposition. The mid-sagittal plane should be vertical. Coming to the central ray is directed in the middle of the skull so that the X-ray beam passes through the cantomeatal line 90 degree to the film, and these are the exposure parameters as seen on the slide. In the modified method, allows this superior border of the petrous ridges to be superimposed on the maxillary sinuses and lower third of the orbit, thus allowing the accurate examination of the orbits and ethmoidal air cells. Positioning of the patient similar, forehead nose position. The radiographic baseline is horizontal and right angles to the film. Mid-sagittal is vertical. The central ray, compared to the previous exposure, is directed 23 degree to the cantomeatal line, entering the skull about 3 cm over the external occipital protuberance and exiting at the glabella. So these are the exposure parameters used for this projection. These are the few radiographs showing PA view, where you can see the first images of multiple myeloma, where you can see multiple punched out lesions in the cranial vault. The second one is cleidocranial dysplasia. Here an electric bulb shaped skull is seen. Third is hyperparathyroidism. Now the two arrows which are marked by red, what you can see is radiolucent areas. Okay, these are nothing but brown tumors which are seen in hyperparathyroidism cases. Next, coming to radiography of the maxillary sinuses. Under that, we have 4 projections. First is standard ospitomental projection, modified method, Waters view, and Bregma-Menton view. In the first one, that is standard ospitomental projection or 0 degree OM view, this projection shows the facial skeleton and the maxillary antra and avoids superimposition of the dense bones of the base of the skull. It is especially used to investigate the sinuses, to investigate Leafort 1, 2, 3 fractures, zygomatic complex fractures, nasoethmoidal fractures, coronoid fractures, orbital blowout fractures, investigation of frontal ethmoidal sinuses and sphenoidal sinuses if the radiograph is taken with the patient's mouth open. This is how the standard mental view is seen. These are the frontal sinuses, these are the orbits, this is the maxillary sinus on either side, nasal septum, nasal cavity, you have the ethmoidal air cells here, coronoid process of the mandible, condylar process of the mandible. This is in a closed mouth position. This projection is taken in a closed mouth position. Film placement similar. The cassette is placed 90 degree to the floor in a cassette holding device. The long axis of the cassette is positioned vertically. Positioning of the patient here, the chin and the nose has to touch the cassette. Okay, the patient is positioned facing the film, head tipped back so that the radiographic line is at 45 degree to the film, also called as nose chin position. Now this positioning drops the dense bones of the base of the skull downwards and raises the facial bones so that they can be seen. The central ray is directed horizontal and at 0 degree through the occiput, and these are the exposure parameters. Now the ospitomental view, this is the normal view of an ospitomental view. So what all we can see over here is the areas marked with the yellow color are the frontal sinuses. The areas marked by red color is the orbit. The area covered by light green are the nasal and ethmoidal air cells, and the dark green areas are the maxillary antral. Now on either side you can see the profile of the elephant. Okay, that is nothing but the zygoma and the zygomatic arch. Now this resembles the profile of the elephant, and hence the profile of the elephant has been pictured over here. Okay, so now each zygoma and zygomatic arch resembles the head and trunk of an elephant. Coming to the Waters view, excellent view to evaluate all the sinuses of the face, that is the maxillary sinuses, frontal, ethmoidal and sphenoidal sinuses. And you can also visualize all the walls of the maxillary sinus and to evaluate any abnormalities in these areas. Also you can see the orbits and structures like the temporal bone. Film placement, the cassette is placed 90 degree to the floor in a cassette holding device as mentioned earlier. Here, again, here this projection can be taken in both open and closed mouth view. In open mouth view, what happens is only the patient's chin has to touch the cassette, and the patient's head is tipped backwards, and the patient is asked to open the mouth. Now, here the mandible should be parallel to the floor, and the canthomyatal line should be at 37 degree to the plane of the film. The central ray is directed at 90 degree to the midpoint of the film. The ray enters to the vertex and exits from the acanthion, as in the image over here, enters through the vertex and exits from the acanthion. And these are the exposure parameters required for the Waters view. Interpretation. So how do you go about interpreting the Waters view? Step 1, which is what you can see in the image over here, the darkened area. So first you evaluate the calvarium and the sutures starting from the right side and then going to the midline and then the left side. So look for any intracranial calcifications or abnormalities. In step 2, you evaluate the orbits and the frontal sinuses. So any abnormalities over here, please mention it now. Step 3, you evaluate the maxillary sinus and the nasal cavity and check for any abnormalities. Step 4, evaluate the zygoma and the zygomatic arches. So as mentioned earlier, the zygoma and zygomatic arches resemble the profile of the elephant, which can be readily seen in this picture in the darkened areas on both right and left side. Step 5, evaluate the condyle and the coronoid process of the mandible on both the sides. So this is how a Waters view is obtained. How it is how this is how the Waters view appears to us. The frontal sinuses, orbits, nasal septum, nasal cavity, ethmoidal air cells, maxillary sinus, maxillary bone, zygoma, zygomatic arch, and the mandible. These are the mastoid air cells which can be seen on either side of the skull. Then there are three anatomic contours which are best seen in the Waters view of the face, and were first popularized by Dolan et al. Now these are the three lines of Dolan. As you can see in the image over here, it's written as 1, 2, and 3. One is nothing but the orbits. Second is the zygoma, and the third is the zygomatic arch, okay, which resembles the profile of the elephant. These are termed as Dolan's lines. Then Waters view is also important to evaluate fractures. Now, as you can see in the image over here, you have the midline, which is marked by the dotted line. Then you have three lines, that is red, orange, and the green line. So what are these lines indicate? These lines are nothing but McGregor and Campbell lines. These were introduced by these two authors. Now, these lines are visible on OM and the OM30 views, which act as anatomical references to assess the facial bones for injury. So the red line, as you can see in the image over here, it passes through the zygomatic frontal suture and runs across the upper edges of the orbits to the other side. The next line is the middle one, or the orange line. It follows the zygomatic arch, zygoma, lower part of the orbit, nasal septum, and then the other side. Okay, and the third one is the green line, which passes from the right condyle coronoid, passes through the maxillary sinus, in the maxillary sinus on either side, and then again to the coronoid and the condylar process. Midline is to assess any asymmetry. Now, these lines, that is McGregor-Campbell lines, are very important in to evaluate facial trauma. So once you obtain this radiograph, you have to draw these lines. So when you're drawing, if you feel if there is any discontinuity, that means that area has a fracture. Okay. Now, apart from McGregor-Campbell's line, there were two more lines which were introduced, which are termed as Campbell and Trampnell's lines. That is the fourth and the fifth line. The fourth line runs across the right ramus of the mandible, lines of the occlusal plane, the left ramus of the mandible. The fifth line runs along the inferior border of the mandible from right to the left side. So this is a classic example, or an example of facial trauma. Once you get a Waters view, when you start drawing the lines, the red line is drawn properly. The second yellow line or the orange line, when you are marking, what you can see is there's discontinuity. Wherever there's discontinuity, the line also is been drawn as a discontinuous line. So wherever there is discontinuity, that means there's a fracture. So here you can readily see there's a fracture of the right zygomatic arch. Again, a tripoid fracture. Here you can see a fracture, the zygoma fracture, zygomatic arch fracture, inferior infraorbital rim fracture, and here fourth, there is breach in the lateral wall of the maxillary antrum. So these lines are very important to evaluate facial trauma. This is another picture showing an orbital blowout fracture. This is the normal side where there is proper continuity of the inferior margin of the orbit. Here there is discontinuity and a teardrop sign, which is nothing but orbital blowout fracture. Next, coming to bregma menton view, as the name suggests, the X-ray passes through the bregma and exits through the menton view. So this projection demonstrates medial and lateral deviations of any part of the mandible. Film placement. The cassette is placed in horizontal position on top of a metal table. The image receptor is tucked under the chin as far as possible. The mid-sagittal plane should be vertical and 90° to the plane of the film, and chin is extended as far as possible, as seen in the pictorial representation as well as the picture of a patient. Only the chin will be touching the cassette in the center. Central ray enters through the bregma and exits through the menton, and these are the exposure parameters. Next, coming to radiography of the base of the skull. Under that you have SMV or submentor vertex projection. Now this projection gives a full axial view of the base of the cranium. So you can see symmetrical projection of the petrosa, mastoid process, foramen ovale, spinosum canals, carotid canal, sphenoidal sinus, mandible maxillary sinus, nasal septum, odontoid process of the atlas and entire atlas, axial inclination of the mandibular condyles. This is how a standard SMV appears to us. So you can see the mandible, you can see the palatal surface, cranium, zygomatic arches. Indications for this projection is any destructive extensive lesions affecting the palate, pterygoid region or base of the skull, investigation of the sphenoidal sinuses, and assessment of the mediolateral extension of any lesion if it is there in the posterior part of the mandible. Film placement. The cassette is placed 90° to the floor in the cassette holding device. The long axis of the cassette is positioned vertically. Position of the patient. The patient's head will be facing the cassette, as you can see the image over here. The patient is asked to sit comfortably on a chair and asked to extend the neck as far as possible so that the center of the skull touches the cassette over here, as seen in the image over here. The central ray is aimed upwards below the chin with the central ray at 5° to the horizontal and centered an imaginary line joining the first molars. These are the exposure parameters. Now in SMV, the exposure time is around 3.7 seconds. So as this radiograph requires extending the neck as far as possible to get a good view. So any patients with cervical spondylitis or cervical spine fracture, this view is contraindicated in such patients. Next, coming to radiography of the zygomatic arches, this is nothing but a modification of the SMV which I spoke of earlier. So the patient positioning, everything is same. Only thing is here the exposure is reduced to by 1/3 than the normal SMV. So as you can see in the image over here, the patient positioning is similar. Once the patient has been told to extend the neck and touch the skull to the center of the cassette, the midline has to be assessed. So central ray is brought as close as possible to the patient. Exposure parameters, it is approximately 1/3 the normal exposure time for an SMV. So this is how a SMV jug handle view appears to us. This area, what we could see clearly in an SMV, that is the mandible, the skull, or all these areas are not properly seen in this radiograph. Why? Because we have reduced the exposure by 1/3. So you can only see the zygomatic arches. Okay, in the second image over here also you can see the zygomatic arches clearly, and in the second image these arrows indicates discontinuity. That means there's fracture of the zygomatic arch. So it is termed as jug handle view because the zygomatic arches resemble the handle of the jug, and so it is termed as jug handle view. Now, all these radiographs which I spoke of, I mentioned telling a cassette has to be placed in a cassette holding device. Now, all these radiographs were taken in a standard traditional machine, panoramic image. Now, as the digital imaging has taken over, what the cassette has been replaced by a sensor, as you can see in the image over here. The patient positioning of whatever of all the radiographs which I spoke of earlier remains the same. Only thing is, instead of a cassette, there's a sensor which is attached, and then the exposure is made. Thank you.